All right. Well, thank you, Pam, for organizing, and thank you, everybody, for joining us today. My name is Eileen Bulger. I'm a trauma surgeon at the University of Washington in Seattle, and I'm co-PI for the National Trauma Research Action Plan, along with Michelle Price, who's here with us today from the Coalition for National Trauma Research. We're very excited to have the chance to meet with you and share with you the results of the study. This is the first in a series of webinars that are focused on dissemination of the results of this project. Today we'll be focusing on two of the panels, one for critical care and one for acute resuscitation. And so I'll give a little bit of introduction about the project and let the panel leaders present the results. And then at the end, we'll have some time to talk about just how you can get access to data for secondary analysis. So this is a research project that was funded by the U.S. Army under a contract. Of course, the views are the views of the authors and not the Army. Go to the next slide. So here's our webinar agenda. As I said, I'll give a brief overview of the NTRAP project. We'll hear about the critical care panel from Dr. Brazel and the acute resuscitation panel from Dr. Constantini. And also an example of a secondary analysis that's already been done on venous thromboembolism by Dr. Constantini. Then I will share with you some of the website resources that we have for this project, how you can access them, how the data has been tagged for secondary analysis, so you kind of understand that, and then how you get access to it. So that's the goal for this session. By way of background, this project came out of the 2016 NASEM report. You recall that report really looked at the strengths and weaknesses of our national approach to trauma care, and specifically called for a national trauma system. And one of the key recommendations in that report was that we develop a national trauma research action plan. So we took that to heart and submitted a grant to the DoD for this project that we're going to describe. Next slide. This project has been managed and led by the Coalition for National Trauma Research, and we are incredibly grateful to all of the partners you see on the slide here who are members of our coalition. The mission of Center is to enhance trauma research in the United States by advocating for sustainable research funding that's commensurate with the burden of disease, coordinating research across professional organizations that span the continuum of injury care, and really enhancing our national infrastructure for multi-center investigation. And I think you'll see that this project is an example of how Center meets that mission. Next slide. So the original grant had three specific aims, and the aim we're going to be talking about today is work that was done under aim 1. And aim 1 was designed to perform a gap analysis of both military and civilian trauma research, to identify what our research priorities were and make sure that we address the entire continuum of care. Next slide. To do that, we developed 11 Delphi panel focus areas, and you can see them listed here. And as I mentioned, we're going to talk about two of these areas today. We're going to talk about the critical care panel and the acute resuscitation panel. We will, in subsequent webinars, cover all the other ones that are listed here. So over time, we're working to disseminate the results across all of these panels. Next slide. We up front in this project engaged multiple specialty societies, all of whom submitted names for representation on the various Delphi panels. So it was truly a multidisciplinary expert panel strategy. Next slide. For those of you who are not familiar with the Delphi method, this is a strategy that's well defined for reaching consensus. We were able to do this virtually, so we were able to continue to run during the pandemic, but it's a way of bringing experts together and maximizing the benefit of those experts to reach consensus without overly dually influencing each other. Next slide. And this is how the process worked. We had a series of Delphi rounds where we asked members of the panel to generate research questions in areas where they thought there were gaps in the field. We then shared systematic reviews and the state of literature in that field with the panel. And then over time, the panel rated the priority of the questions that they had developed through a series of rounds to prioritize the questions and reach consensus on the priority of those questions. Next slide. There have been a number of publications already to date. These have all been published in the Journal of Trauma and Acute Care Surgery and can be found on the JTAC's website under a collection. So if you click at the top of the website under collection, you'll see the NTRAP manuscripts all in one place so that they're easily accessible and also be available on the center website. Next slide. All right, I'm going to turn it over now to Dr. Brazel. Dr. Brazel, introduce yourself and tell us about the results of the critical care panel.
Hello, thanks, Dr. Bulger. My name is Karen Brazel. I use she, her pronouns, and I am was the lead of the post-admission critical care. My, I guess, night job is as an acute care surgeon at Oregon Health and Science University, where I also am the general surgery program director. And it was my privilege to lead the critical care panel. We had a diverse group of panel participants, and I will say that Delphi consensus does not mean that everybody agreed equally, but it is a way of coming to the voice of the panel. And the reason I preface with that is really to highlight the richness of the data set. So even if something didn't rise to the greatest priority, there are data in the data set that you might be interested for a particular research question that you have. And I really, really, really encourage anybody to use these data, to use the publications that have already that are already extant to support your own research. Hopefully, this will provide some guidance so that we can, that we all collectively can start to answer some of these questions. Next slide. We started, identified some gaps, and then generated questions. And we generated almost 600 research questions. Some of them were informed by our own practices, our own opinions, the patients we take care of. Some of them were informed by research that existed that we took a look at. As I said, not everybody agrees about everything. 250 of these questions reached a consensus level of 60%. And of those, 22 were deemed high priority. Most of them were medium priority, and very few of them were low priority. So there are a lot of ways that you can sort of look at that overall main result. There's a lot of stuff in the middle. One way to look at it. The other way to look at that is there are some things that are really high priority. And even in those 22 questions, there's some overlap. So there are some things that we really, really, really do think out of all 600 that we started with are important, and we need as a community to find the answers to. So those are most frequently things addressing traumatic brain injury, and you will see some overlap with the neurotrauma panel, and hypovolemic shock. Next question, or next slide, next question. So the top 3 specific questions, does the use of whole blood improve outcomes compared to the use of component therapy? And that was above and beyond the highest rated, both from a consensus standpoint, and then you look at the mean score. And so that touches on the hypovolemic shock question. The next specific question, does the routine addition of ketamine within 24 hours reduce narcotic requirements and delirium? Almost as high. And you can sort of put this in the bucket. Questions that related to delirium and that overall topic was rated very highly. I think that highlights the patient population that many of us see, and the number of geriatric patients and the difficulties in caring for geriatric trauma patients who are frail with comorbid diseases and now have traumatic injury. And then the third question, in trauma patients after initial resuscitation and after bleeding control, does a fluid de-resuscitation protocol, active rather than passive, reduce outcomes, specifically mortality, ICU days, or ventilator days, compared to no de-resuscitation? And again, fairly high, both in terms of mean score and consensus rate. Next question, or next, God, I keep saying that. When you look sort of overall, and I've alluded to this already, hemorrhagic shock, traumatic injury, traumatic brain injury are the clinical states of greatest interest. They're, and one of the takeaways, and you can again look at this with either a positive or a negative spin, there's a lot of congruence with other groups that have done similar work that is not exactly the same. And you can say, that's great. All of us who have this expertise agree where we should go next. You could also say, come on, guys, we've been saying the same thing for a while. This is what we really need to do. There's congruence with the AAST critical care research agenda. There is international agreement, a publication out of Australia, New Zealand, looking at current challenges in critical care. One of the things that I was really happy that came out was that short and long-term outcomes other than mortality are viewed by the research community as important. Additionally, the impact of caring for these patients and how we choose to care for these patients, the impact on physicians and other members of the healthcare team is important, and we need to study it. So those were sort of the takeaways from the data and the 22 top consensus questions. Next slide. The biggest gaps, resuscitation is a sort of a global gap. What should we use? How should we monitor it? And when and how should we stop? Preventing delirium, can we prevent it? Or can we mitigate it? And how, if so, can we do that? Use of specific agents, and does sleep hygiene just make us feel better, or does it actually help our patients? And then investigating how we communicate and its impact on us as healthcare providers, routine family meetings, the use of palliative care, primary versus secondary palliative care. So those are the three biggest buckets for gaps. Next slide. And so again, sort of circling back to that first, what are the most important questions to answer? Does whole blood improve outcomes? And does ketamine reduce delirium? I think that's my last slide. No, one more. Secondary analyses. Use of therapy in the ICU, specifically physical therapy. There's actually not a lot of data on early mobility in surgical and trauma patients. So you could do a secondary analysis on physical therapy, but therapy more broadly. Secondary analyses focusing on the healthcare team specifically. Lots of questions, didn't reach the top 3, but lots of questions about viscoelastic testing. And there was more than one question looking at different outcomes or different populations related to de-resuscitation. I alluded a little bit to the congruence with the neurotrauma panel, and I think there are some possible secondary analyses looking cross-panel, and things are tagged similarly across panels so that we have the ability to do that. Cross-panel with neurotrauma, cross-panel with what Dr. Costantini is going to come after and talk about. And then a lot of congruence with the pre-hospital panel focused on resuscitation. So I think there's some really exciting opportunities for cross-panel as well as secondary analyses within the data set specific to critical care. That was my last slide.
Terrific. Thank you, Karen. And I think obviously a high-level overview. The manuscripts will give you even more detail and all the top questions in the table and all of that. So please take a look at the manuscript for more detail on the critical care panel. But as she said, we think there's a lot of opportunity cross-panel, and we'll talk more about that. I'm going to turn it over now to Dr. Costantini, who led really the largest panel that we had. Because we lumped into his panel not only acute resuscitation, but initial patient evaluation and imaging issues. So quite a broad array of topics, and I'll let you present and introduce yourself to the group, Todd.
Great, thank you, Dr. Bulger. Good afternoon, everybody. My name is Todd Costantini. I'm an acute care surgeon at UC San Diego and also serve as the trauma medical director here. And as Dr. Bulger mentioned, it was my great pleasure and a great opportunity to lead the acute resuscitation panel. Next slide, please. I just want to start by amplifying a little bit of some things that Dr. Brazel said. And the first is, please use all of these data that exist across the NTRAP panels. And I think, you know, these questions that have been generated, I think, can be really useful to researchers for a couple of reasons. The first is, if you're a junior investigator and have an area of interest but aren't sure what questions you want to ask, or what questions might be fundable, or what questions might be good to start your research career. I think this is a rich source of information for that. And I think for more senior investigators as well, if you're writing a grant application, as we all know, the significance part of the beginning of the grant is key, right? And what better way to say the National Trauma Research Action Plan identified this topic as a high priority topic, and that's why I'm studying it. So if I'm reviewing a grant, that gets you a high score in that area. So I really think it's important that we think about all the questions that are here and think about using them. So as Dr. Bulger noted, I had the pleasure of working with this panel and had definitely the largest set of issues. So really this panel spans the initial and acute resuscitation in the trauma bay all the way through definitive management of injuries. So that is a pretty robust topic and spans quite a few different areas, as you can imagine. And our panel actually initially developed about 1,400 research questions, which we were able to, over multiple rounds, able to come to consensus on 992 questions. And so there are a lot of questions in this panel. About a third of those questions were deemed high priority in a consensus fashion. A majority of the remainder were medium priority. And interestingly, if we were able to get consensus, nobody really thought those were low priority issues. So we actually had very few low priority questions. And there's some themes that you're going to see that come up in the highest, sort of the most high priority questions. And you'll find as well that there's quite a bit of cross similar interest in things across different panels, as you'll see some themes that were similar to Dr. Brazel's panel as well. So some of the highest priority research topics related to pharmaceuticals, that can include TXA or direct oral anticoagulants, things like that. And then also really one of the main drivers of the questions in this panel was the fluid and blood product resuscitation. When we broke things into specific injury patterns or diagnoses, we found that some of the highest interest was in traumatic brain injury, vascular injury, pelvic fracture, and VTE prophylaxis. Next slide, please. So lucky for you all, I'm not going to read through all 992 questions that we developed in this panel. So we're going to hit a couple highlights. But really, we're just going to hit a few questions here. What's really important that everybody also recognize is that for most of our panels, the entire list of questions exists as supplementary digital content within that Journal of Trauma website. So if you want to go see all 992 questions, That is available for you to access. You can pull out an Excel spreadsheet and see every single question in there. So this is freely available for you to look through and to use. So what were the top questions in the acute resuscitation panel? So again, very similar to the critical care panel, our highest priority question related to the use of early whole blood in the pre-hospital period and whether or not it improved outcomes in patients with hemorrhagic shock. So that question received a mean score of 7 on a scale from 1 to 9 and had very high consensus. The next question, which again is a theme through some of our high priority questions, related to the effects of permissive hypotension. And this question relates specifically to moderate and severe TBI and whether or not what our goals of resuscitation should be in this population. But I can tell you very similar questions exist when you talk about patients who are geriatric. Should they have different goals of resuscitation? What about in, adolescent population? Is it different in those populations? So really a lot of interest around that topic across many different pathologies. And then the last related to TBI prophylaxis. And again, there's another theme here. This question relates specifically to the optimal timing, agent dose in initiating chemoprophylaxis in patients with TBI. But we also, again, saw similar questions related to high-risk injuries like blunt solid organ injury or spinal fracture or spinal cord injury, and a lot of questions about what's the best dose. Can we use other agents such as aspirin or Lovenox? So a lot of questions in the high priority list that related to TBI. Next slide, please. All right. So again, what stood out? Well, there is a lot to go through in this panel. 992 questions, many high priority questions. You're probably hard pressed to not find a high priority question that's related to some area of research interest of yours. So again, I recommend that you look through that list. Next slide. The biggest gaps related to hemorrhagic shock and transfusion, and specifically a lot of interest in whole blood, both in the pre-hospital and during the acute resuscitation, the use of TXA, whether it was for the early hemorrhaging patient. There was some crossover asking questions about TBI, which crossed over with the neurotrauma panel. There's questions about the risks related to TXA administration, like venous thromboembolism. We also had several questions related to fluid resuscitation and adjuncts. So again, what are blood pressure targets? Can we or should we develop novel fluids or factors that we can give patients to attenuate the inflammatory response, or have stockpilable medications that can alter trauma-induced coagulopathy? And again, the issues related to permissive hypotension and what should that actual goal be in different populations. There were several questions again related to venous thromboembolism. One we didn't talk about, there was a high priority question related to post-discharge prophylaxis, which is an area of interest and probably even more interest now that the metric study is out, giving us some insights into how we might at least approach that from a medication standpoint. And then the last is related to pain, and I would say specifically non-narcotic pain control. So several questions about ketamine, questions about multimodal pain control. Should we be using gabapentin or not? Should we be using NSAIDs in patients with fractures? And then how should we most optimally deploy regional anesthesia across many different injury patterns? Next slide, please. All right. I just wanted to show you a couple of those high priority questions. Again, I showed you the first question already in the initial slide, but here's another question related to shock and transfusion, which asked the question about which population should get TXA in the pre-hospital setting. Some specific questions related to those fluid resuscitation. Again, we talked about the issue of permissive hypotension and TBI. We see the 8th ranked question was the same question in geriatric patients. Again, pretty high interest in determining what our goals of resuscitation actually should be. Next slide. And then related to VTE prophylaxis, or the diagnosis and treatment of VTE, we had 3 questions in the top 10 related to VTE, again, related to the timing of initiation in TBI, the timing of initiation in spine surgery, and then what the heck should we do when patients are discharged, because it's pretty clear that their VTE risk doesn't magically disappear the minute they go home. Next slide, please. All right, so we've all alluded a little bit to secondary analysis. So it's pretty clear that many of the research areas that we're interested in or that you might be interested in are not localized to one specific panel. And it's so, therefore, I think there's a great opportunity to do secondary analysis to look for your favorite research topic across all of the NTRAP panels. So at Dr. Bulger's suggestion, we went ahead and took on looking at all issues related to venous thromboembolism across all panels, and actually found 86 questions that were distributed across 9 NTRAP panels. And Dr. Bulger is going to show you a little bit about the process of how that works. But just so everyone's aware, not only have we kind of tagged all of the research questions with a taxonomy to list them by sort of patient age or patient-related conditions, or the specific diagnosis like VTE, or specific treatments like medications, you can actually query specific keywords within that database to ensure that you're not missing anything that was maybe not tagged perfectly appropriately. And so by doing that, we were again able to come up with 86 questions. You see a majority of them, or at least 32 of them, came from the acute resus panel. There was 21 questions from the burn panel, 14 from the critical care panel. And you can see on down the line with just a few questions as you got down to pre-hospital. I was a little surprised that the orthotrauma panel only had 1 VTE related question, as this is an area of debate and constant discussion in our ortho trauma conference meetings at my institution. So I think there is certainly some opportunity for some questions that cross over pretty significantly. When we look at specific topics within those 86 questions, the most common topic related to timing of initiation, related to all sorts of different injury patterns, operations, open abdomens, things like that. People were interested in questions related to risk factors related to VTE prophylaxis. So does race or sex alter your risk of VTE? Does specific injuries, does specific resuscitation protocols alter that risk? A lot of interest as well in TXA and its effect on VTE throughout the hospital and post-hospital course. Questions related to dosing, medication choice. Can we start using aspirin in patients? Should we be using DOACs, or is that a research question that we should be studying? We had questions related to treatment of VTE. And then fewer questions related to complications. Again, patient factors. Are there specific genetic or immune profiles that make individuals more at risk than others? Diagnosis, should we be doing routine screening on these people? Post-discharge prophylaxis, and then a little bit on IVC filters and important issue related to patient education. Next slide, please. All right, so here's again a couple of those specific questions. These were all high priority questions. One was, should we be individualizing our VTE prophylaxis strategies based on clotting profiles or specific genetic factors? So not giving a one-size-fits-all approach. Another question again was, how long, if we're going to give post-discharge VTE prophylaxis, how long should it be? 2 weeks, 4 weeks, 6 weeks? And I think obviously within that, how does injury patterns, immobilization, splinting, weight-bearing status play into those issues? What is the risk of VTE after TXA, which again is a concern of many who see a lot of TXA being given. And then what's the risk of VTE after reversal of DOACs, which is obviously something that we do not infrequently in our center. What's the risk of VTE and thrombosis in general in those patients? Next slide, please. All right, I'll turn it back over to Dr. Bulger.
So thank you, Dr. Costantini, and I hope you can see how rich this data set is and the opportunity. I wanted to have him show you that's the first secondary analysis that's been done, but you could pick one of 1,000 other topics that you might have an interest in and search across all the panels and do a very similar type of analysis, which I think will be very beneficial. So how do you get to this data? So all of this is housed on the center website. And we put a little QR code, make it really easy for you today. But if you just search NTRAP or center or whatever, you'll get to this website. On the center website, it's under research. And then there's a whole National Trauma Research Action Plan page. And so that's the landing page for, access to all of this information. Next slide. What you will find on that webpage is an overview of the project, which can be useful for methods. We are working on an executive summary, which should be out there soon as well. There's a sign up link for these webinars. Eventually these recorded webinars will be up there too. So if you miss one, you can catch it later. There's a subpage for each aim of the project that explains how it was done. There's a link to all the published manuscripts. There are links to who was on the Delphi panels, if you want to get a sense of the level of expertise of the participants. The strategy that we use to tag all the questions is clearly described, along with what's called the taxonomy, which is basically our data dictionary, and then a data request form. Next slide. This is just a sample of how we tag the research questions. We couldn't fit the entire taxonomy on a slide, but again, it's available on the website. But basically, we took each of these areas, you know, what patient population is it? What phase of care is the question related to? What injury pattern and so forth? And we developed a structured list of keywords that you could search. So if you wanted to search, for example, all the military relevant questions across all the panels, you could do that. All the geriatric questions, although, you know, across all the panels, you could do that. So you could pick one of the keywords here, or you can get your own keyword. As Dr. Constantini said, we have a keyword search strategy that you can look for actual keywords within the questions. So working with our team, we have various ways to help you pull this secondary data across the different panels. Next slide. This is how you ask for it. So there's a data access request form on the website. We ask you to fill it out. Tell us a little bit about your project. We have a review process because we don't want everybody doing the same project. So if there's somebody else that's already working on it, we can connect you to them. But this way we can keep track of what's going on, and we can make sure that we get you the data that you need. Next slide. So I'm going to end there. I think we have plenty of time for any questions you have for any of us. Again, I want to thank you for joining us today, and I look forward to many secondary papers coming out of this project. So I'll open it up now for any questions that you guys have.
Hi, Dr. Bulger. It's Michelle Price.
Yeah.
I was thinking it might be helpful to just quickly tell them about where the how the mean scores were derived on the items.
Oh yeah, so basically all of the questions were rated on a Likert scale from 1 to 9, and we considered, you know, scores in the range of 1 to 3 to be low priority, 4 to 6 to be a medium priority, and 7 to 9 to be high priority. So over time, you know, each Delphi member had to rate every question and then review the scores of other people's to try to reach consensus. And so they might adjust their score one way or the other based on the comments from other reviewers to settle on a mean score. So the mean is the score, you know, across all the panelists for that particular question. And then it had to reach a 60% consensus threshold in one of those categories to be included. And then that's what the score means. So a mean score of 7, you know, is pretty good. It's a mean out of across the whole panel on the scale from 1 to 9.
The other thing that I thought we might want to tell the group about is that for those of you who participated in the panels, thank you again for contributing your expertise. One of the benefits of having been on a panel is that there are no data embargoes if you served on a panel. But if you did not serve on a panel, there is a 1-year embargo from the time that panel's data appeared as an ahead of print publication. And you don't need to worry about when that expires. But if you submit a request to us, if by chance that paper has not quite yet met that embargo, we will let you know. You'll be the first in with that request for that, you know, that analysis. But we may need to wait to allow the panel members the 1 year that we said we would give them exclusive access to the data. We're coming up on 1 year for most of the papers, so it may not be an issue, but I just thought we should mention that too.
I would also say a list of panel members is available on the website, so you can probably find someone on there that's a friend of yours. So if you're not a panel member and you want to do a project, you can partner with a panel member, that will solve that problem.
The review process, if you do submit a request, takes about a month. And then we reach out to you directly and provide a data use certification that we ask you to sign. And then we send you the data in very easy to use Excel spreadsheet format with a key to all the taxonomy and the attributes of the data as they've been described.
Any other questions? Must have been a very clear presentation.
Yeah, there's lots of potential for these secondary analysis. I really encourage you to think hard about that, and feel free to reach out to me if you want by email, or really any of us if you have questions about, you know, what you're looking for and what you might be able to find. Obviously, it's important to remember these are a list of questions. So if you're, you know, you can't find granular detail necessarily about a specific topic, but if you're looking to generate questions and demonstrate the importance of it, I think this is a great place to go.
Dan, would you like to tell everybody about the next seminar?
Sure. I'm sorry. The next webinar in the series will be March 23rd. And it is covering, well, I don't remember which panels it's covering, but it's you can find that information on the NTRAP website, but it'll be March 23rd in the afternoon.
We also have an investigator database on our website. If you're not already signed up for that, you probably are because you're here. But if you're not already signed up for that, please sign up, and that way you'll be on our mailing list, and you'll get, you know, activities that center's doing in addition to NTRAP. All right. Well, I guess we'll wrap it up there, but thanks everybody for joining us, and thank you to Dr. Brazel and Dr. Costantini for presenting, and for the center team for all of your support, and we'll see you on the next webinar.
Thank you all for coming.
Thank you, everyone.
Have a
Take
good day.
care.
Thank you.